thank you very much. It's such an honor to be here and be with so many old friends and so many new friends and such an incredible, distinguished panel. I'm going to be speaking a little bit about limbal stem cell reconstruction. It's one of the really, really tough problems that I face. It said in the program SLET, but I noticed that the next speaker is also speaking about SLET. So I've added in really all limbal stem cell reconstruction. I have no financial disclosures, and we just heard a great talk about dry eye and the ocular surface, and all of these components are necessary to maintain an ocular surface, and the limbal stem cells are really crucial. And when the surface starts to break down, there's pain, foreign body sensation, tearing, and you manage the dry eye, any sort of neurotrophic aspects. If you have a 5th and 7th nerve palsy, you have to do a tarsorrhaphy. And then structural disorders to rule out any other problems. But unfortunately, sometimes the cornea will look like this. And you have limbal stem cell failure, 360 degrees. It can be relatively mild, but it will progress. The limbal stem cells are really necessary to propagate and distribute the corneal surface. You need really about 25 to 30% of an intact limbus to maintain a good surface. So that gives a little bit of a strategy for taking the stem cells from the fellow eye to the non-affected eye. And initially, when you start to have a breakdown on the limbal stem cells, you start getting a dull, irregular surface, you get a loss of light reflex, and you begin to get corneal opacities. And you have conjunctivalization of the corneal surface, and that's characterized by having goblet cells, which you can see. You get a whorl epitheliopathy, looks a little bit like amiodarone toxicity, and eventually you can get non-healing epithelial defects, stromal neovascularization, and as I mentioned, when you look at confocal microscopy, you see goblet cells migrating onto the cornea. So what causes limbal stem cell deficiency? Really lots of things. Aniridia, a lot of congenital conditions, autoimmune, inflammatory, of course, cicatricial pemphigoid, vernal, as we just heard, graft versus host disease, Stevens-Johnson, multiple surgeries, chemical burns, radiation overexposure, contact lens use, herpes simplex, which we heard about, can also lead to limbal stem cell deficiency, trachoma, neoplasias of the ocular surface, degenerations, ulcerations, so much. But the big question is, what do you do? When it's early, we can often manage it with just topical lubrication. Systemic vitamin A topical vitamin A and systemic doxycycline can help. Autologous serum drops can be very effective in maintaining the surface, and we often will use a scleral contact lens. But there are times it gets too far. You have scarring, stromal ulcerization. In a case like this, there's no conservative treatment that's going to manage this cornea or this cornea or this cornea. So the first thing you can do if you have an intact other eye is do a graft from the fellow eye. I used to take 3 clock hours from up above, 3 clock hours from down below. So I was taking 6 clock hours from the healthy eye and transplanting it. I got reasonably good results, but I had a few times that we would have a pseudopterygia or issues on the donor eye. So quite a few people started looking at, can we grow limbal stem cells in a tissue culture, put it on an amniotic membrane, and then replant it on the eye? And then Virender Sangwan, quite brilliant friend who used to be at the LV Prasad Eye Institute, he's now at Shroff's in Delhi, he came up with the idea, well, hold it, if we're doing tissue culture, the eye is a good tissue culture media. So why not, instead of taking 6 clock hours, just take 2 or 3 clock hours, risk less damage to the fellow eye, and use the eye as your growth media. And so he developed what he published as a simple limbal epithelial transplant. And this is a quick video from actually Virender showing, it actually has sound, but I'll just narrate it. It's a fairly simple procedure. A lot of times the pannus will be easily peeled off of Bowman's layer. And you basically just begin by taking the limbal biopsy from the donor eye, from the fellow eye, and you just place it in BSS. And then in the recipient eye, you do a complete excision of the pannus, and then you, so this is just a video showing how to harvest. You start with a peritomy, very small here, just making a small little cut in the, with the blade as you come from the conjunctiva into the cornea, and go about, I usually go about 1.5 millimeters or 2 millimeters into clear cornea and excise that and then put that in saline. Then on the donor eye, you basically dissect and peel the pannus off, and then you cover with an amniotic membrane. Then place, you take the cells that you want to have proliferate, and you place them onto the amniotic membrane that's now on top of the bare Bowman's layer. I cut them into little pieces, and again, this is the idea is you're using a tissue media. It's sort of culturing these cells on the cornea, and you divide it up and spread it out around the cornea, and then put a bandage contact lens on and a tarsorrhaphy. And in a few cases, I've had miracles. I'll look forward to the next talk and hearing other people's experiences with SLET. I've had about 3 or 4 great miracles. I'll just show you one case in a second. But I've had probably about a 1/3 great result, 1/3 pretty good result, and 1/3 of my SLET procedures have not restored vision. So this is, again, from Virender, just showing some great results and some of his papers with really good long-term stability. My best, and Shambang just published recently showing about 83% overall success rate with 60% restoring to 20/60 vision. This is my one giant success. This is a little boy who had an alkali burn, and he's now 6 years out from his SLET with 6/6 vision. But a lot of times you'll have bilateral injuries. You'll have diseases like aniridia where it's affecting both eyes. And then this is a much bigger quandary. Ed Holland in America has written about taking living-related donors and doing transplants from living-related donors. I personally don't have any experience with it. I have been doing some keratolimbar allografts. Ed Holland reports a little bit better results than I've been getting. But I've been doing the keratolimbar allograft from a cadaver donor, and different case reports are reporting about a 33 to 80% success rate on the eye. The big problem is that these are very close to the limbus, so they have a big tendency to have inflammatory reactions and reject. And I've had a couple of people who've not tolerated the immunosuppression. We treat them. I do it in conjunction with my kidney transplant team at Stanford. We manage them usually with triple immunotherapy and treat them again like a solid organ donor. You take the donor rim and you thin the donor rim, and then you peel the pannus off. And this is a video of a case. And I had already noticed this patient, he was a monocular patient who had limbal stem cell deficiency in his fellow eye. They had tried to do a PK, and he had an expulsive hemorrhage and actually lost the eye. So he was very hesitant to have any kind of penetrating surgery done. We knew that he had a white cataract. We could see through the inflammation, so we were prepared to do a cataract. I'm doing a big tenons dissection as well. There was a lot of inflamed tenons. And as I mentioned, these often will peel very nicely and quite easily off of Bowman's layer. And so this is peeling off of Bowman's layer. and just polishing a little bit. And now I actually have a nice view. So at this point, I did the cataract surgery, which was really a relatively routine cataract surgery. It was a relatively soft cataract, so this was not the big issue. And again, a lot of times the big issue on these is really the immunosuppression and how do you kind of manage these patients long term. And I look forward actually to hearing some of the other participants' comments on how they manage these patients. Like then doing a fairly generous temporary tarsorrhaphy and post-operatively triple immune therapy, topical corticosteroids and cyclosporin, and I was prepared to do a future penetrating keratoplasty, is what we often have to do. In this case, his clinical course I'm sorry you can't read this, but at 6 weeks, his vision was 2800, and at 3 months, he was 2200, and at 6 months, he was 2050 with a scleral contact lens, and at 2 years, he's 2020 with a scleral contact lens, and he never needed a penetrating graft. But unfortunately, he also got quite ill from the immunosuppression. He also had high pressures from the steroids. He underwent a tube shunt now 2 years out. And so some of the real difficulties with these cases are the management post-operatively. And another option for severe limbal stem cell deficiency is the keratoprosthesis. This is the Dolman type 1 keratoprosthesis. But these also have a high incidence, at least in my experience, of long-term glaucoma. There's also problems sometimes with extrusion and also with prosthetic membranes. So I don't really have a great solution. I struggle. The unilateral limbal stem cell failure, we do quite well. My results with SLET have not been quite as good as with my previous limbal stem cell autografts taking 6 clock hours, but it's much less morbidity to the fellow eye. And the keratolimbal allografts for patients like the patient I just presented, who's a monocular patient and really quite desperate. There are some miracles, but there are downsides with the systemic care. So I look forward to hearing what a couple of the other presenters have, and thank you so much for your attention. And I wish I could play some music for you. That was just such an honor to listen to.
I know, it's becoming a bit more like a variety show, but that was very interesting. Do you find that the extent of the damage to the ocular surface is like a predictor of how well they'll go, whether they'll fail, and or
I don't know. I mean, that boy who now I've been following, actually it's been 8 years, who still has 6/6 vision, who had as severe of a alkali injury as one could possibly have. And after SLET, he is 6/6, 8 years later with really a very normal appearing eye. And I've had several who were much more moderate whose SLETs have failed. And for keratolimbal allografts, I don't do it unless it's really a desperate situation. So I've never done a keratolimbal allograft on a mild case. Mild cases, as I mentioned, I manage with serum tears, a PROS lens. It's a really wonderful scleral contact lens that has been a real miracle for quite a few of my patients and who've been sort of creeping along and with very functional vision when you would be very surprised they could get it. So my first line really is the PROS scleral lens.
And you mentioned vitamin A. Are you doing that as retinoic acid? Do you get that compounded up?
Yeah, we get compounded retinoic acid and doxycycline in all of them.
The first SLET is close to 14 years old now. And we had published a series on pediatric SLET which had grade 6 burns and total, very bad damage. The only thing that we learn from there is if there's a damage of conjunctiva, then you'll have to replace that conjunctiva. So those cases, you'll have to do a simultaneous conjunctival autograft as well, because the limbal strips or these cells that we place, it can make a corneal phenotype, but it cannot replace the conjunctiva that has been damaged. So that's what we have learned, and this long term it works beautifully well. I think it works better than CLET. And whatever problem that you have, like recurrence of symblepharon,
I'm sorry, you were saying what works better than SLET?
SLET long term works probably better than CLET, the cultivated limbal epithelial transplant that we used to do, long back. So, and whatever problems that we have, like recurrence of symblepharon, generally you have it in 3 to 6 months' time. So once that time is over, so probability that something will happen, it's very less. We have now, I think, 7 or 8 cases who are more than 10 years old SLET and doing very well. Regarding allografts, we are saying that if the patient doesn't have other eye to take the limbal biopsy from. So there we have done a few patients where we have taken the limbal strip from a live related donor, preferably brother, sister, or maybe son or daughter. And there the only catch is that you'll have to give systemic immunosuppression, sometimes 2 drugs, sometimes 1 drug, and they also seems to be doing very well, and probably the result is equivalent or slightly better than the keratolimbal that
so you're doing
like in acute burns. Geeta has published a paper where they have used a cadaveric limbus just to ensure that the epithelialization is faster after the acute burn, and that also does decently well.
A lot of times in these severe cases, you do get a lot of tenons inflammation, and I found it's had much better results sort of dissecting the tenons and getting to just pure, nice conjunctiva.
Thank you. Might move to the next.